Hi.
Well, thank you so much. I can't be any more honored and thankful for the opportunity to be able to speak with all the providers here on this call. And Howard gave me a call and he said, it's up to you. You can speak on any topic you want to talk on. And I couldn't think of a better topic to discuss with such a group of motivated and uh, just driven individuals to help our community members. And today we'll be speaking a lot and spending a lot of time on social determinants of health. As I mentioned, my name is Brandon Eldershaw. I am the manager of community wellness at CentraState Healthcare System. I work out of the department referred to as the Health Awareness Center, and that is a department where we provide services focusing on four pillars of health: eating well, moving well, relaxing well, and managing well. And services that are really going to provide our community members with the resources, the skills, the relationships needed to live a healthy lifestyle. Out of our department, we have a social determinants of health program, and we actually have on the call Anthony Verone, and he is the supervisor of population health. And also on our call from our team, we have our director of population health, Mary Ellen Teichman. So throughout the presentation, we'll start to introduce them, and Anthony will give us a little bit of insight on how we are really reaching our underserved populations and how our social determinants of health program is working here at CentraState. So what are we going to cover today? We're going to do an overview of social determinants of health and how it really impacts the health status of our community members. We're going to be diving into a little bit of New Jersey statistics and the most vulnerable communities that we see here in our backyard. We're going to touch lightly on some hospital readmissions and how this is tied into that. And most importantly, we're going to open this up to a discussion and really start to discuss how we can work better together. A lot of this is really being able to identify populations and provide them with the services they truly need. So what is SDOH? So SDOH is broken down into 5 domains. So you're going to have economic stability, education, access to healthcare, environment, and social and community context. So the economic stability is really the umbrella to each and every one of these domains. This has such a dramatic effect on all of these other domains listed below it. When we look into this, people with steady employment are less likely to live in poverty and more likely to be healthy. And why? Why are they more likely to be healthy? It's because it's what they have access to if they have steady employment. We think about having access to healthcare, right? Having access to PTO and paid time off. If you get sick, you're able to still get paid. Having access to a safe environment, to be able to live in a community that is going to provide and has access to clean air, water. Here in Monmouth County, we even have, and we see a huge lead issue. So being able to employ those individuals and give them the opportunity to have those resources they need to improve their lifestyle habits. And the most important 2 factors that are really tied to steady employment are going to be your transportation and your technology. And we look at transportation to where individuals don't have access to healthy food. They don't have access to going to their doctor's appointments. And by opening our doors to individuals that live in vulnerable zip codes, we're able to really help them with the resources they need to live that healthy lifestyle, right? And we think about technology. There's so many resources out there, and us as providers, now it's a new norm. We're providing resources on demand, but there's so many individuals that are underserved within our community and local service area that don't have access to Wi-Fi, they don't have access to a computer, they don't even necessarily maybe know how to use those technology devices. So it's just so important that we really try as a community to continue to raise awareness of opportunities to those that live in vulnerable zip codes, of areas that they can get steady employment with benefits and et cetera. And here at CentraState, we do have and employ a large amount of the underserved population through our housekeeping and food service departments. And that really does affect each and every one of these domains. We dive into education, and people with higher levels of education obviously are more likely to live healthier. And this is where it's so important that we provide healthy lifestyle education programs like diabetes prevention, congestive heart failure, hypertension management. You think about yoga classes, Tai Chi classes, behavior modification programs that are going to provide these individuals with the knowledge they need to make the right decisions. And as we go through this presentation, we'll look at the statistics, but it's eye-opening to where those that live in a vulnerable zip code do not have a high school education. So how can we provide them with other education that's going to affect their health and well-being and how they are making healthy lifestyle choices? Access to healthcare in Monmouth County, there's a vast amount of individuals, and again, the statistics will highlight this, that do not have access to healthcare services. Environments, we touched on this lightly, but think about that. Those that live in an area that is not so safe, they can't even go outside and walk their dog and implement physical activity. We need to raise awareness of public parks and transportation and get them to a safer environment. So a lot of different areas and domains to think about. Social community context here at CentraState, what we've done is we've implemented an employee event, as I mentioned before. We do have a vast amount of the underserved population employed here at CentraState, and they attended this employee fall festival that we hosted here at CentraState. And the first thing they said was, "Is this free?" And they brought their kids. And their kids came and they were able to interact with the DJ and the trunk or treat and games and resources and vendors and prizes, food. And it was this great event. Thinking as a community at large, ways we can partner and implement a one-stop shop event that is really going to give those families a very much needed night out. And that's what this was for our own internal staff, and we received great feedback and just start to get the wheels turning there of things we can think about. So some statistics focusing on those domains that we started to talk about. In 2019, Chart published in New Jersey's most vulnerable communities. And how did they identify the most vulnerable communities? Is by looking at poverty levels, age, race, ethnicity, and other variables. Variables such as, undocumented status, disabilities, Medicare insurance. And that is where we start to see, okay, that's how we identify these individuals. So look at some of these statistics here. The median unemployment rate for zip codes for the poorest health status is 14.4%. So we talk about how not only are they unemployed much less than the average percentage of 5.9, but their household income is much less by 55%. And as we just kind of really showcase how that can truly affect one's health and well-being and access they have to everything. We talked about that education and the importance of that. Quick data on this is those that live in the poorest health status zip codes are 27% versus 7% statewide. So we're seeing a lot of these individuals that are living in these vulnerable zip codes are not educated. So how can we provide education to those individuals? And something that we have to take in consideration is going to their locations and convenient locations. Again, they don't have technology and they don't have transportation. So how can we bring these services like a diabetes prevention program to a convenient location? How can we provide that service in their preferred language? So these are the types of things that we need to start to think about. Access to healthcare, the median percentage uninsured for zip codes with the poorest health status is 18.7% versus statewide median of 6.3%. And this year, as I'm sure that, all of these hit home with us, but this one hit home the most is to where those that are living in these vulnerable areas are living over 4.5 years less. So just more statistics there. And then now more looking into our backyard here in Monmouth County, as a lot of providers on this call are located within Monmouth County. They had the rankings within the most vulnerable zip codes, and with 1 being the best and 537 being the worst. And as you see here is just a quick highlight of those areas that we have within our county that are labeled as a vulnerable zip code. So hospital readmissions here at CentraState, we're seeing a vast amount of people using the hospital for the wrong reasons. They're coming here for a healthy meal. They're coming here for a place to stay. And that we have resources out there for them in this community that they should be utilizing rather than coming here to the hospital. And that is not just here at CentraState. That is a, statewide issue. And this stat kind of highlights that. 91% of visits of 1,000 is 91 visits per 1,000 is due to really those wrong reasons compared to the 37 statewide. So something there that we're starting to see. And again, here at CentraState and all healthcare systems, we do not get reimbursed if an individual comes back within 30 days. So it's very important that when they do come to the hospital, it's for the right reasons, and then we're providing them with the resource they need to stay out of the hospital and to stay well. Emergency departments visits with 2 or more chronic conditions and diagnoses. So we're talking about hypertension, preeclampsia, congestive heart failure, diabetes. These are areas that we can really start to prevent readmissions by providing those resources to the community before they get to that point to where they, always need to come to the hospital and continue to come back. So we do implement a vast amount of services and programs that are going to provide those educational pieces they need to make the right decisions. But as you see here is just a quick highlight of what we're seeing as well. So these next 2 slides, I'm going to hand it over to our supervisor of population health. His name is Anthony Verone. He has done an amazing job growing our SDOH program, and he's going to start to talk about the 2 most important factors, which is screening and referring. And how are we doing it here at CentraState, and how we can work better together by doing it all. Everyone on this call as a provider can work better together by implementing these types of resources within your target populations. Anthony?
Thank you for that introduction, Brandon. Hello, everyone. Before I get started on the slides, a little bit of background information on myself. This work with Social Determinants of Health has a special place in my heart, given that my first job out of undergrad was working actually as a community health worker, doing this kind of work with Atlantic Health System. So I am responsible for the direct supervision of our Social Determinants of Health program. And a lot of our program design is based on the UPenn model that Atlantic Health uses, specifically how we conduct the screenings. So let's dive into it a bit. What is the purpose of our work? It's really to improve the social determinants of health screenings in our facility. What we're able to do by doing that is to identify health disparities and resource gaps in the communities. Things like, what truly is impacting our communities? Is there a food desert or lack of providers in an area that we might see a higher proportion of diabetic patients from? Things like that. We want to identify the true needs of the population, not just based on their visit to our medical center, what is top of mind for them, but as we ask these questions to more and more people, we increase our sample size and get a better understanding of what the target population thinks that they need help with in their community. And additionally, we'd like to raise awareness. A lot of our patients oftentimes are not aware of the resources that are available to them. Given that we have the knowledge, it's our job to disseminate that information to them in a clear and concise way so that they can utilize those services to improve their overall health and well-being. So the structure of our program, I helped to develop it with our AVP of Integrative Health, and that is our health equity coordinators screen patients 2 days per week and 5 to 10 patients per day. They utilize an EPIC report that shows recently admitted patients. So they focus on the inpatient units, but they also go to the emergency department as well. Our health equity coordinators go through that list of patients and look for individuals with needs based on their EPIC chart. Some areas that we focus on within the EPIC chart are, whether or not they have 2 visits in the last 6 months. This could tip us off and let us know that there's something more acute going on with this patient, that something has progressed and they need additional help. We look at the different social determinants of health domains within the wheel and EPIC. So transportation, smoking, financial insecurity. There's a snapshot within the patient's chart that highlights those areas. If it's green, they do not have a need. If it's red, then they do have a need. So we look there. We also look to see if they have a PCP or insurance. And also we look into their current visit, so their H&P for the reason why they are here. Why are we doing this work? During this last year, we received word that Joint Commission and CMS were going to require all New Jersey state hospitals to screen every inpatient for social determinants of health. So we wanted to get a little bit ahead of the curve. So that's why we started our program. And this is a good segue into our next slide. After they ask you to screen patients for needs, what are they going to want to see next? They're going to want to see us refer to services. So that's what we've been doing. And the purpose of this call is we want to refer better together. We want to build our network and utilize all of the different organizations in our service area to help alleviate some needs from our patients. So we're working to connect our patients to the resources and services that they need. This will allow us to prevent inappropriate use of the emergency department. Oftentimes we see, people coming into our emergency department for services that they could receive at their primary care physician's offices. For some of our low health literacy groups, they use the emergency department for diagnostic testings, pretty much as a one-stop shop. And often they only start utilizing it once their disease has progressed. So we want to catch them earlier along in that cycle and help alleviate those needs so that, improve their overall health and well-being. And we want to connect those patients directly to the services that they need so that they don't get burnt out trying to look for it themselves. We have the knowledge and the information. It's our job to give it to them. So how are we going about doing this? Starting in June 1st of this year, we launched a pilot program with Unite Us and Atlantic Health. We were originally using the web-based platform. We're utilizing Unite Us to send referrals for our patients directly to the community-based organizations to streamline our process. Since inception on June 1st, is now fully integrated in our electronic medical records, so we can go directly from a patient's chart in Epic to Unite Us. It automatically creates a patient's chart, and then we're able to send a referral directly to that organization for that specific need. So it's really implementing the Unite Us software into this workflow has really streamlined our process. And we want to, eventually grow our community-based organizations, our partners on that. And if any of you are interested, I'll get into more of that later. So what are some of the most common needs that we see amongst our population that we've been screening? They're transportation, primary care physician, insurance, financial assistance, and medication assistance. For transportation, given the location of our medical center, we're kind of in between Monmouth and Ocean County ride services, our primary population. So that could be a challenge sometimes because when we refer to those ride services, they're not allowed to cross county lines. So that has been a challenge that we've been able to navigate by adding more, services to our network. For the primary care physician aspect, if our health equity coordinators see a patient that has no primary care physician and no insurance, then we refer them to the closest FQHC to where they live from their patient origin. If they have no PCP but they have insurance, then we refer them to the family practice locations to keep them in-house. And for the insurance and financial assistance, medication assistance, we do a lot of referring to the County Board of Social Services and assist them with applications for things like prescription assistance programs, SNAP, WIC, all those kinds of benefits. And we also do for the medication assistance, we send in applications to the pharmaceutical manufacturers for supplies of meds. They could typically get somewhere between a 60 and 90-day supply of meds from the pharmaceutical manufacturers for relatively cheap, much cheaper than you would get them, from different pharmacies. So that's been very helpful. And then there's organizations like Needy Meds that are in our network on Unite Us that we're able to refer directly to, and they do some of this work with our patients and they outreach our patients as well. If anyone is interested in utilizing Unite Us, I know that it's really helped us kind of streamline our process. It could streamline your process too, bring the patients directly to you once you list your organization on their website. But we'll make sure to drop our primary contacts information into the chat box for all of you, so that if you are interested, that you can go directly to the person that could get you set up with all that. So that's kind of the high level overview of our program. And I'll pass it back over to Brandon.
Yeah, thank you, Anthony. I think he did a fantastic job kind of highlighting everything that they are doing so well with our SDOH program. And now, if Howard allows us, and what the next steps would be, but we're going to open this up to a discussion, questions, and we listed some questions here that may start to spark some interest and conversation as well. But again, thank you all for attending, and thank you all for the opportunity for us to be able to share with you what we are doing here at CentraState, and an opportunity for us to discuss how we can continue to partner with our community organizations.
All right. Well, thank you so much, Brandon. This is a really incredible amount of information. I mean, this is such a broad topic. I'm sure there's going to be quite a number of questions. So let's jump right into it. Does anyone have either a question for Brandon or Anthony about the material that was covered today? Any questions? If not, I have a question, and it's really more so about the crisis versus kind of the prevention that I think Anthony was highlighting. Where are the biggest opportunities as you look at the social determinants of health? Like, what are the trends? Where are the biggest where's the biggest crisis? I know you mentioned, lead poisoning. It's amazing to me, and I've heard Tara mention this as well, as that's something that's still going on in our community. But I think of, things like, heart disease or smoking cessation, things like that. Like, what are you guys seeing as like the number one drivers of the crisis? And is there a way to get out in front of that in the data that you're seeing through kind of population health?
I could take this one. I think one of the biggest needs, one of the drivers is definitely financial based. Given the nature of our primary service area, we have demographic. The demographic is very widespread. We have a large population of aging individuals who are getting out of the workforce. We have a large population of migrant workers and seasonal workers and things like that. So a lot of that can be based on financials and food deserts, other things like that. So what we do on our end is we try to meet them in their communities, ask the questions, and then assist as best as we can with the infrastructure or connecting them to the closest resource to them. Brandon, do you have anything else to add?
No, Mary Ellen, do you?
Yes, I just unmuted myself just to talk about the medical community at large. One of the biggest issues now, I think, is a lack of physicians throughout New Jersey. And, connecting them with primary care is essential. And I think that's what our nurses are doing. I don't know, Anthony, if you want to talk a little bit about what the RN health coaches do, like with heart failure and that, but really just making sure that they're connected with a primary care physician who can manage their care. So they're not using hospitals, and that's not only statewide, that's nationwide. A huge problem where people just go to the emergency room because they're having a problem with heart failure, and they're readmitted over and over and over again for the same things. That we can, if they have a primary care or a physician that they can call or nurses that they can contact, and we can take care of some of that stuff, and we don't have to send them to the ER and increase the medical cost nationwide for using hospitals for readmission. So, but Anthony, do you want to say a little bit about what the nurses do on their end?
Sure. Yeah. Our nurses in the last year or so have really kind of slid into more of the transitions of care roles. So they're, meeting patients on the floors with specific disease conditions. This year, we really built out our heart failure program, so made it more robust. So they're following our heart failure patients for an extended period of time now, and the goal is really to after they're discharged home, that we outreach them. We reinstill that education that is given at bedside and make sure that they're making their follow-up appointments and that there's consistency with their care so that they do not come back in within the 30-day window. So we are working to, really help bridge that gap for our patients in the transitions of care space and get them connected to the right physician for their disease condition.
Awesome. Other questions?
Howard, I have one.
Go ahead, James.
How you doing, Anthony? Brandon, how you doing? We met last Zoom. One of the questions on your last slide. This is the first I'm hearing about this Unite Us platform. On the last slides, how do you become a provider on that Unite Us platform?
I'm so happy you asked. So I dropped the information in the chat box. That's our primary contact with Unite Us. Avery, she kind of supervises our service area. So if you're interested in getting your services listed on the platform, I would suggest to reach out to Avery via email and say that you're interested in one of their information sessions. They host regular information sessions every Thursday, the first Thursday of every month, I believe, but don't quote me on that specifically. Avery is the right person for that. So they host these information sessions where they explain to you the process of getting on to Unite Us, what their standards are. I believe some of their standards are that they would like you to, respond to referrals that are sent to you within 2 to 3 business days. So she will outline that entire process, what it looks like for you. And then you sign an agreement with them. They list your services, and then they require that there's someone from your team on the other end that's waiting, that will receive the referrals and answer them in a timely manner. So I would suggest I dropped Avery's contact information in the chat box. If you'd like, I could reach out to her on your behalf as well. But those information sessions, and then you sign an agreement afterwards.
All right, thank you very much.
No
Awesome.
problem.
Good question, James. Any other questions?
Hi, it's Jeannie Wall. I'm not a healthcare provider, but I cover healthcare. And I have a question. We really found out about the deficits of the digital divide with our seniors, especially, and our low-income New Jersey residents during the pandemic. And I know there were many efforts to provide electronic, tablets and different things like that for, the people that needed them. Now, are those initiatives, still happening? Or I remember there being more of a deficit in South Jersey with our seniors and with our youth more in North Jersey. There were different pockets that were really desperate. So are there initiatives now to continue to help that become more balanced?
I can definitely speak on that a little bit. So when it comes to providing educational resources that are on technology for the aging population, I'm not sure if this would be what you're asking, but here at CentraState, what we do is we have a program referred to as the Virtual Senior Center. And that is where we implement that within an affordable housing community. It gives residents access to all of our pillars of wellness and education. And that's delivered through an activities coordinator or resident service coordinator. And it's mirrored from a computer onto a projector. And this is recorded content that allows that population to be able to access technology and education. But I'm not sure if that's directly targeting your question, but
no, that's great. I think that's great that those programs exist. I think it's so important because those that do not have the electronic access are missing out on, all of the benefits.
It is. It's a huge challenge. And, we partnered with Spring Point Senior Housing, which is well over 9 affordable housing communities We partnered with United Methodist Communities, Affordable Housing Communities, and implemented this program within those. We partnered with Leading Age New Jersey and Delaware that really represents our virtual senior center and sells it on our behalf to their members. They have a vast amount of providers and communities, CCRCs, affordable housing communities, local senior centers that provide that belong to them. So that's kind of how we have our foot in that space. But great question, thank you. I think we have two more questions down here with Andrea and.
Yep. Go ahead, Andrea.
So, Brandon, I know that, CentraState also offers evidence-based programming as we do at SCAN, and we bring it right into the community. And we have found over the years very difficult to recruit people. And even once you recruit them, it's a tough sell. Diabetes, there's some lifestyle components. A lot of people, their answer is, well, my doctor will just up my meds, or, there's a tremendous resistance to improve yourself, to take, that self-management thing. And I just wonder, do you find the same thing, or do you have a secret to this?
Yeah, no, it's a great topic that you bring up. I mean, you think about this, it's a trans-theoretical model towards our target populations. They all fall somewhere in a trans-theoretical model. And that's why it's so hard to get them to the level to where they're really ready to implement a behavior change. And that's where it's, implementing these types of relationship building activities and programs that are free and accessible and convenient, and gets them to realize, hey, I really do need to quit smoking, so I should probably join the smoking cessation program. I didn't realize my A1C is falling in this category. Let me implement a way of life diabetes prevention program and follow through with that. So, what we really see is it's building relationships, getting them to that next level, raising awareness, educating them on the importance and how that, a risk factor can be identified as something that can only get worse. And by raising that type of awareness, we're starting to see that they're starting to get into those programs. And again, a lot of it also has to do with the referral channels that we have out there within the community, working with our community-based organizations, community relations, chambers, things like that, to get referrals, and then to be able to build a relationship through health coaching and then move on to the next long-term service. But great topic. Yeah.
All right.
All right. Thank you.
Yeah, great question, Andrea. One time for one more question. Was there one more?
I was just going to ask, going back to the transition services that you guys recommended, I think it's crucial. I represent Fox Rehab of Monmouth. We have 60 clinicians that are in the homes, and they are the eyes, sometimes the only people that see these patients. Is there a direct contact for that program, a way to learn more, just so we can make sure that, patients are properly educated and know that there's a resource for them after? And then you mentioned it's your NPs. Is that led by a head geriatrician? Is there a social worker, case manager concept in there? Was just curious to learn a little bit more and where I would do that.
Mary Ellen, you want to take that one?
Did I hear you? I'm sorry. I love Fox Rehab, by the way. Did I hear you say NPs?
Yeah, I believe that he was saying our nursing staff is.
Oh, so our nursing staff is not like Fox Rehab. It's our RNs and they are not managing meds or anything like that. They're kind of following up, making sure that they could talk to somebody with heart failure about, their weight, about when to contact the physician. So they are not nurse practitioners.
Okay.
So did I answer your question, or?
So it's more, no. I get that they're further educating them and on next steps as well, right?
Yeah.
Upon discharge. I didn't know if there was anything after that to recommend a follow-up visit or anything like that versus going into the ER when these things happen. So just if there was a way to learn more, if it's an exact program or it's just something that they're starting to do more of,
So we are always trying to get into new disease management, but currently they're working mostly with hypertension, preeclampsia, and heart failure
Okay. Thank you.
currently. But I'd love to get your contact actually. if you
Absolutely.
want. Thank you.
Thanks.
All righty.